Okay,
Can you,
Anu?
yeah, case number 9, we are back in room 2.
Yep.
Same, I'm with Parasuram, Jason, and Maria. So this could be the last case in this room. So we're going to introduce our staff. Where is Will? Will is the chief, I would say. You see that? He is the chief live case nurse. So every time we do live case, he is on here. Yes, and then we have who? Kim and April. Yes, Peter and Asif are our techs. So if you see here, case number 9, a 90-year-old male who had angina class 4 and he's referring, didn't do any others because of, limiting angina, significant risk factors, was sent here directly for cardiac cath without having any of the previous tests. So EF was mildly reduced. And then when he came here, he had significant 3-vessel disease. So prior stent and RCA was totally occluded. LAD had a proximal disease and circumflex also had multiple lesions. Of course, because of the age, despite syntax being high, patient and the referring doctor, after discussion, patient, of course, did not want bypass. So we did circumflex at that time. And today he's here for PCI of the LAD. So if you see, angiographically, this is where the circumflex, all the prior stents look good. And you see the calcium, tight lesion. It's not any stent, it is just a tram track calcium. He has a diagonal disease also. But I think given his age, we can just focus on one lesion. Now, having shown so many complex diseases, the theme here would be, again, how can we manage calcified lesions using imaging? His creatinine is good, so we decided we will do OCT, but let's take how would you approach this case that you have? So significant disease, short, focal.
The landing zone after the lesion, has that like a calcium nodule there or something?
Yeah, that's what we also felt, that even on the angiography, we can confirm it with the
OCT.
Anu,
imaging.
I
Now,
think
if we,
the OCT, of course, will give us all the clues as how to proceed, but completely agree with your decision to leave the diagonal alone.
Possible.
is Kiski here?
Yeah.
Okay, now we're doing OCT
Yeah,
when
can you check
you
the
tell
pop?
me, right?
Yeah, it's very tight stenosis, so.
Yeah, can you, okay, you have to give some dye.
Yeah, good clearance.
Okay.
Okay, 1 second. Enabling, 1 second. Waiting. Yeah, cine, inject. Yeah, we got image. You can take it out.
Is there any prior stents?
Looks
Or
like,
it's all calcium?
1 second, please, sorry.
No, a little bit more. Middle lady.
Oh. No, we're not going to do that, right?
Yeah.
Flush it.
Okay, angiocorrelation. Okay, start of the pullback. Yeah, mid has some previous stent, but here is open.
So it's prior stent?
Yeah, this is, but not much intima. Big, so this is the tightest lesion. So it looks like not calcium.
Where is the calcium? Yeah.
Do you see calcium or no?
Right.
Okay, 1 second. So first, the OCT didn't show any orange line. Like a little bit here, like 90 degree. But the tightest part, it looks like it's not that much calcium.
I don't think the OCT is giving the truth here.
Well, if you look at it, it has a glow like it's soft tissue, right in
Yeah,
the
no,
core of
it looks, yeah.
angiographic.
Distally you see that, but
This is,
proximally it's look all like lipid-rich plaque in the
It
proximal
really
segment.
does have that kind of glow
So look
to
at
it.
that, it's totally diffused.
yeah, and no, like a well-delineated border and like attenuated plaque. Yeah, looks like possibly lipid plaque.
Maybe we just cut it then.
Yeah, we
No,
can check
I
the
think-
dilatation.
Let's see the fluoroscopy.
It does, though, on angiography.
You know,
There's a
the-
soft tissue glow to it.
Maybe, well, what about the experts here? Dr. La Sala, tell us what to do now.
Well, if we've agreed upon there isn't a whole lot of superficial calcium, all of it's got to be deep based on the angiography, correct?
Change it.
No.
Yeah,
just saying-
for some reason, this is the first case in my life in which I don't believe the OCT. I think there's
Yeah,
that lesion is calcified. Look
in
at
our lab,
that.
we would say, get the IVUS.
Yeah, that's what I was gonna
Yeah,
say. Take the eye.
that's a good one.
Or just take a non-compliant balloon, go up, see if it expands. If it
Yeah, I think
doesn't, then
that's-
do shockwave.
Shockwave doesn't care whether it's superficial or deep, so that's always an option.
Yeah.
But I think you could just balloon it and just see how it looks like on
Okay.
a.
If it
Okay,
balloon-
get us a cutting
if it
balloon. Let's
balloons
go
well,
in
I think
between.
you're
3-5
done. Just
cutting
stand.
balloon. Yeah. Yes.
Yeah, so is the one limitation of OCT, the depth of penetration.
What do you think, Kiski?
Yeah.
Now that you've done so many OCTs, we have analyzed so many calcific lesions. Why you think we are getting this?
So first,
Look at the fluoroscopy. I just did the fluoroscopy cine.
yeah, I mean,
Track.
first it's a very tight stenosis, so the blood clearance is not perfect.
Did,
And I see some small calcium, like distal to that lesion.
did you
But
do
the height-
this? Did you do this pull back on manifold or automatic injection?
We did,
We did assist. Earlier the case we did it with hand. Okay. I think it's right there, right?
yeah, usually OCT is better for detailed calcium assessment, but the presence of the calcium IVUS might be better than some moderate OCT.
Okay, let us see how it behaves. Oh.
No, but this, yeah, opened up. What size balloon is this, Anu?
3-5. We went up to 18. Let us do another round of OCT here, okay? Go. Are you telling me this is a proximal edge of the stent?
Outside of stent. Like 5 millimeter proximal to the previous stent.
So you think there was no lot of dye clearance, that's why we could not see it?
That's one possible.
Okay, so let us do another run of OCT.
Yep.
Okay, done.
It makes sense that it may be a new plaque if there's a previous stent there. Right?
Are we, you think it's a lipid rich?
I do.
What is the
No, I'm on the
vessel
OCT also.
size distal
Yeah.
to the lesion? What is the vessel size up there? Up there?
So actually, after the lesion, it's kind of like an aneurysm. The lumen is like 3.9.
3.9, okay.
Yeah, but looks like proximal is smaller.
And what is the length between the ostium and that landing beautiful zone you just measure?
We didn't come to the ostium, but ostium to that distal reference is like 10.8.
Okay.
Oh, sorry, not ostium.
I think it's the manifold.
Okay, second run of OCT.
Yeah.
Yep. So can you check the path again?
Oh. Should you increase the,
No, we can do. Good clearance.
1 second.
1 second.
They have a dye.
Okay, so can you enabling? 1 second.
Start cleaning.
Bleeding.
I think we have a dissection.
Yeah,
the
Cine,
dissection
inject.
Yeah.
oh,
Yeah, good.
Big dissection, yeah. Contain.
yeah, perforation. Forget
I
dissection,
know,
contain
I know.
perforation.
Contain perforation, yeah.
It's a deep wall
This is
dissection.
the, oh, so it was a lipid rich. The cutting was too much. I go with a papyrus up front.
No. What do you see?
Okay.
We have,
So-
oh, deep cuts.
Yeah. A lot of plaque modification. Yeah, a lot of dissection.
There's a
Okay,
section.
get us a Megatron.
Okay. Dr. Kirin, now I see some calcium here. Here.
Yeah.
Like eccentric
Okay, okay.
calcium and protruding inside.
First, let's stabilize this lesion.
Yeah, this is much better image. Now I see definitely calcium nodule.
Okay.
3.5.
3.5 is a good one, or you want us to put a 4.0?
Proximal lumen is smaller and it's less than 3.5.
3.5.
Yeah,
Yeah,
better
I
to
just
go.
3.5, 16, quickly. And then let us see, we can then decide, you need a papyrus or we stabilized it. They have that or open a,
It's kind of interesting.
Bleeding
It's-
into the
Looks
plaque.
like a
This plaque
hematoma.
here is rather interesting that it's.
do you
so-
see anything?
Yeah.
Like a hematoma?
Yeah, it's
Yeah,
a
I
intramural
see. For,
hematoma. yeah.
dissection,
Big dissection,
intramural,
but
so the
evolving
dissection-
into a
There's a hematoma
hematoma.
Some and another lumen.
Deep dissection, right?
Me- measure
another
that.
lumen behind the previous stent. So, but the lesion start at our tightest lesion. So there is some medial dissection. Like it propagates through the previous stent, behind the stent.
Okay.
Interesting.
16, right?
Yeah.
Okay, so the
I think the OCT was
TYE
right.
length is 16. What is your imaging length?
Wait,
Have a papyrus ready?
go back to that image.
1 second. Yeah.
5 you gave me, right?
Actually,
3.5.
13
See,
13 is
the-
enough, so 16 is enough.
What happened
enough
is
to
that
cover.
the hematoma is make you think that the vessel is larger, but the vessel is not that big. So
Yeah.
So I will
Okay,
go.
Connect. Some die. Yeah. Some
A
die.
lot of contrast.
And the tightest part is again the 1/2 is plaque free, so don't go aggressive is better. So it might cause another perforation.
Okay, so we are not going to go. No, we are 3.5.
Yeah, so that's the great safest one.
See if we
Sine?
cover the whole
3.5
thing.
and then make it bigger if you need to.
Oh, wow.
Oh, gosh.
Yeah.
Really bad. Okay, go
I
up.
think you're right. You're good.
90-year-old tissue, you know.
Don't go to 18.
Yeah, 218. No, we did not. Yeah, now we are 12.
We've got the right size
Down.
papyrus ready?
Yeah, the papyrus is ready.
Down.
I think it's just deep intimal tear.
I
do.
think we will
Yeah,
deep
I think it's
intimal
just-
tear,
you
we
can't
will
be sure until
stabilize
after
with
you
the
see
stent.
it.
Yeah.
It's just bleed.
We knew it was
I
a
think
deep
it'll
intimal
look
tear.
better after this.
Okay. Go a
That's
little bit inside there,
Basically a
right?
perforation.
Go up there again. Don't go too high. Yes.
As long
Okay,
as
down.
it doesn't squeeze down to the circle.
Yeah, the shape of the balloon on the stent is very encouraging. There's no bulge.
Okay, let's take a picture.
Yeah,
Stabilize
I
it.
think Dr. Singh is right
It's
again.
in. Okay, ready?
Yeah.
Yay!
Okay, everything under control.
So it was just bleeding into
No
that
need to
soft
worry.
tissue plaque.
I don't think
There's,
another OCT is required.
and
Eyes are telling us things are looking good.
you can still see that there's a pocket of contrast there, but looks like it's contained.
Yeah.
I'd get a different view there, yeah.
So this one, and then I will take a,
Just for the
LA
fellows
order.
and things,
Yeah,
you have to be
go.
careful post-dilating something like this, that you don't start to expand it proximally.
go caudal. Also take multiple views. I know we can image and confirm everything, but this is the view that's going to tell us anything. Ready? Kiski, you want another OCT?
Yeah, we can show.
I think we are good.
Okay.
Yeah.
That is a little, you see that?
I think retrospectively, the OCT was right. It was a super lipid-rich plaque. The cutting went through the media into the adventitia, contained rupture, now sealed with the stent.
No, actually, after we did the cutting, the second OCT did show lipid. Go back and show the lipid.
A little plaque, a
So
little
not lipid,
calcium.
I mean calcium.
Calcium, yeah, a little
calcium.
calcium,
Yeah.
but all these diffuse.
How much was it? One quadrant?
Yeah, one corner nodule.
Oh. Again, nodule.
Yeah.
The nodule, yeah,
Everywhere.
but that we saw in angiography, the nodule. We suspected it. But it's a very illustrative case. Don't believe angiography, believe in imaging.
Just remember
But this is
how to
not-
do angiography, though. Looking for calcium is that you
This is-
start to cine then give dye.
Good.
And then you can see the different
Do you need
shadows.
another OCT?
Let's
We
see,
can show,
how many
Okay,
vote
he wants
for,
another OCT.
how many will do OCT
Give me
again
plus.
from the podium? None.
No.
Forget it.
Okay, nobody's, okay, Kiski,
Dr. Marina,
you're alone.
how often do you see with neoatherosclerosis, how often do you see calcific neoatherosclerosis versus
Often.
soft plaque?
We see a lot of calcium behind the stent too.
Mm-hmm.
And within the stent for neo is near infrared the way to go.
Mm-hmm.
OCT can give you some idea, but in order to diagnose neo, you do near infrared, and we have a publication with Kinney in Circulation about that.
But usually it's not calcified though, right?
Okay, we are done here.
Is it,
And now we'll go to the next room.
morphologically, isn't this a little unusual that a
we have-
90-year-old
we
who's
have
got
the
diffuse
last
calcium
case getting
angiographically
ready.
had nothing superficial?
Say that again?
Isn't it a little unusual from a morphologic standpoint that a 90-year-old who has calcification throughout their whole vessel angiography does not have anything that's superficial?
I'm not
Yeah.
so sure this is not related
This
to
is
the
a
stent
very
process
good
that was already put in.
Observation
So I
from
don't know if
Dr. La
this is
Sala.
native
Okay, are we moving on with the next case?
Yeah, we can move on, or do you want a quick,
That's why it argues.
right?
You're doing the second run?
No, I have to do the case number 11 also now.
Oh, sorry,
Do a
just
lecture
manual,
in
right?
between, right? Did you tell him? Don't put me on.
That's why you always have to look at the
You can hear me. Pedro, can you do one lecture? Is there a lecture?
No, no lectures. We only have the conversations over complex cases with expert faculty.
Okay, I'm going to the next room.